So rectal cancer, not the same as colon cancer. Big difference. So it's further down, and it's pokier. Okay. We're going to go over the anatomy because it is different in the pelvis. It's confusing even for everybody. And then we'll go over kind of the staging guidelines and your workup for rectal cancer, treatment algorithms, and then kind of quickly, if we have time, this ERAS stuff, because that is very testable. They kind of like that stuff. Anyway, so the rectum. Yeah, so it's so tricky because it's in the bony prominence, or it's in the bony confines of the pelvis. And one thing I always like to point out is, when we're coming from above and you're going down, this is sort of like the extent of where you comfortably see here. And then when you're working, and you're here, and until you really get your fingers in there, you don't realize, but you're going like straight up towards the pubic symphysis because the curve of the sacrum. And so just from a surgical standpoint, that's why you're like working upside down like this and you can't see it. That's one of the things that's so tricky about it. And this is a man, and you can see the seminal vesicles here. She likes to say the pants of a leg. And then you can see the prostate. In this drawing, you can tell from here how if you're doing an APR for rectal cancer in a man, how the prostate and the urethra could be at risk because this is a tight plane here, and if it's an anterior tumor and it's a bit sticky, or even just in normal dissection and it's been radiated, it's easy to actually start pulling the prostate down. This seems like, wow, you must be really out of the way. No, I've seen it. And then you can just go drop right through the urethra. And in a woman, similarly, this is anterior, the vagina can be entered, but it's so much easier for you to prepare that. And so looking here, this is why we always talk about the difficulty of like pelvic surgery and rectal surgery in the colorectal world, especially we say, it's a chubby male, and they have such a much more narrow pelvis here, and so sometimes it's so narrow you can't even get your hands in there. So from a surgical standpoint, how do we define these various portions of this part of the anatomy? So the rectum, generally we say, is about 15 centimeters from the anal verge. The anal verge is generally we say when you spread the buttock apart, it's what you see. There's the perianal skin, which is around there, and everybody has sort of a different definition of how far out is perianal skin. So the anal verge is what you see. The anal canal is if you kind of when you're doing a rectal exam, you'll feel the sphincter complex, and that's the anal canal. Once you kind of get up over the shelf, then you're in the rectal vault. So 15 centimeters from the anal verge, approximately, and as you are working from above, you can identify the rectum by a couple landmarks. The haustra, the tinea coli coalesce, and it's kind of cool for our junior residents. And I wish we had the med students. I geared this towards them, and they're not even here. But you can watch them splay out. Oh, don't read my text. And there's obviously no haustra or epiploic appendages, which is important when you're doing rectal surgery or when you're doing like a sigmoid colectomy, an LAR for diverticular disease. It's important that you get all the way down onto the rectum. The number one cause of recurrent diverticulitis is just inadequate surgery. You leave a couple, and it's funny, you're leaving diverticulum all over the place distally. I mean, proximally, but those aren't the ones that cause you the trouble generally. So anyway, so the intercircular layer, when you're on the colon and in the rectum, then turns into the internal anal sphincter, and that's what we cut when we're doing that is so tacky. That's what we cut when we're doing a lateral internal sphincterotomy. And the outer longitudinal layer does not become the external anal sphincter. These are important for your test. That'll be one of the, it's the intersphincteric fascia. The somatic innervation, so like your sensory and that fecal continence, that comes from your pudendal nerve, which is S2, S4, and that comes in laterally when we're doing a perianal block. That's what you're blocking, and those I've seen some horseshoe incisions for a prostatectomy, and they'll have complete incontinence, like they have no tone or anything and no sensation. And you'll also, that's what's different. When I was in my residency, I remember being taught by chief residents to make a good incision and sweep around in there, make sure you get all the attachments. And when I got to my fellowship and I wrote that in a note, everybody freaked out because you're not supposed to sweep around in the perianal area. When you're doing when you're draining a perianal abscess or anything, you don't sweep around. You just open it. You might put a little hemostat in there a little bit, but you just let it drain and you irrigate it because you're going to disrupt all those little nerve endings from your pudendals, and they're going to be incontinent. And so I hope I don't have anybody floating around out there. I was doing what I thought was good. So don't do that. It's been my mission to come back and spread the wealth. And then so the autonomics. This is very testable as well. So we talk about the sympathetics, and these are from up around the IMA, and that's when those will be injured. So the question will be after an APR or an LAR, the patient they'll describe retrograde ejaculation, and that's because, and they'll say, when was it injured? And they'll give you these really good choices, but it's when you were ligating the IMA. And then the parasympathetics, this is for erectile dysfunction. So when they say, oh, now your patient has ED, it's the nervi erigentes. And then as you come down, as you're taking those lateral stalks, you'll just mess everything up because that's where they've coalesced at that point. And so they'll have ED and retrograde ejaculation, and they won't be able to urinate. Low rectal cancers, I don't think we need to really, I made this, I was thinking it would be interesting. Just know that not all low rectal cancers are created equal anymore. They do not all equal an APR, even if they're right on, when you put your finger in and you feel them right there, that's still, we wouldn't necessarily perform an APR. They can maintain continence. So even like a centimeter above supraanal, juxtaanal, intraanal, and transanal. These we would probably do, even some of these, see how it's invading the internal sphincter? We would still do sphincter preserving surgery, so ultra low LAR. That's crazy, I think, but we do it. So preoperative staging, it's so important to get good staging because it determines your treatment. And the problem is that, say it's whether or not there's a node involved, that impacts what you do before you have surgery, before you have a specimen. And so you would treat them differently if you knew they had a positive node, or vice versa. If I knew they didn't have a nodal disease, I would have just done surgery up front, and they would have had the same outcome. So it impacts what you do neoadjuvantly. If you're able to preserve the sphincter, maybe that's just inflammation. Maybe that was a biopsy, and that's inflammation from your biopsy of the rectal mass, and it's not actually tumor invasion. I've seen our rectal cancer biopsy come back with the cancer in it, but also vas deferens. And so you can tell, they go full, they'll go all the way through. And so then you don't know, is that tumor invasion or, and then, and it really impacts their quality of life, because if you're radiating somebody unnecessarily, they have subsequent cervical cancer and small bowel adhesions and real problems, and they can't heal their wounds. And then just the ability to talk to your patients about, what to expect in the coming year and then the rest of their life. So the staging, it's again, I like it because it's simple. Nodal disease equals stage 3, METs equals stage 4, and then T1, T2, and T3, T4. The only thing that I think is good to know for rectal cancer is why T3 in 1. So a Y in front of the staging indicates that they've had neoadjuvant therapy, and this is after their neoadjuvant therapy. If there's an R ahead of it, that means that it's recurrent. That's the repeat staging. It's not radiation. Y is radiation. R is the repeat staging after they've had therapy, and this is a recurrence. And then P, so oftentimes you'll see on the pathology report at a real rectal cancer center, it'll be YPT 3N1 or something. And that means they've had neoadjuvant therapy, and this is the pathologic specimen. If they haven't had neoadjuvant therapy and it's upfront surgery, it'll be PT3N1 or whatever. And then you feel really bad because they didn't do neoadjuvant therapy and they have nodal disease. And then this other stage here, the N1C, this is tumor deposits. They might have you'll see the pathology report, it will be 0 out of 20 nodes positive, and you're wondering why it's an N1, but it's because there's tumor deposit in the mesentery or the non-peritonealized pericolic or perirectal tissues. So that's a way to have a nodal N1, but in 0, 0 nodes involved. So things that we need to know from pre-op staging, I want to know how far through the rectal wall it's gone. I want to know how much room I have circumferentially, until I'm touching the prostate or the levators. It's the circumference with a CRM, and that's the big key thing for rectal cancer surgery. If I can get an adequate CRM and the nodes don't look positive, oftentimes we won't even give radiation up front. And then whether or not the lymph nodes are involved and distant mets, obviously. And things that we use to determine this, it's clinical exam, endorectal ultrasound, CT, MRI, and PET. DRE is pretty, we make everything complicated. You think, oh, it's just DRE. But things you really want to be able to describe a lot from a DRE. Obviously, the height, and everybody says, oh, no, know how long your finger is. It's a little tricky because if you have a really muscular butt, it's hard to get, you don't know. It might be at the very tip of your finger, and it's in the anal verge. So you have to kind of keep that in the. So we generally have, for us, we care less about distance and more relationship to the sphincter complex. So you kind of keep that in mind. And then, where is it circumferential? Is it 50% of the circumference? Is it mobile? Is it fixed? Is it on a pedicle? When you move it, do you feel the structures behind it moving? And you also need to do a vaginal exam if there's a woman at the same time. So there's a lot of things to it that it's very easy to determine just in that exam. You just have to pay attention to it and generate that information. But it's really neat. They've done studies, and the Colorectal Society shows that you can correlate. There's this clinical stage on DRE and and if you use these terms on a pathologic standpoint, what does that actually entail?
Books, that's a great chart. That's what is asked in the oral exam.
Yeah.
When they're trying to present you a case of APR versus LAR, then they want you to think out loud these 3-4 things.
They'll describe, it's tethered.
Exactly. They will.
And then they're trying to make you think you are not going to be able to preserve their sphincter.
Yes. So this chart, I think, is great. Which book is this?
This
must be a colorectal book.
Yeah, well, this one is from Nichols. This whole DRE.
And this is a great chart, I think. Somehow I've never seen this in Cameron or other general surgery books.
Rigid procto, so we'll go over this, but part of the staging of rectal cancer, you're required to do rigid proctoscopy. To back up, there's a whole push for rectal cancer centers of excellence, and in Europe, where most of the best data in colorectal cancer comes out of, the rectal cancer can only be treated in certain centers because it really has so much better outcomes in places that are high volume that do it all the time. Their pathologists are neat to it, the GI people, and so there are these requirements for, if you're going to do it, you have to have 100% of your rectal cancer patients have to have rigid proctoscopy beforehand, and 100% have any. Anyway, so that's one of the things that's the criteria that we're describing in this presentation. And so tenesmus, tenesmus is one of the biggest predictors of a rectal cancer. People say, oh, I have blood in my stool, or I'm having pain, or whatever. But tenesmus is a symptom that should make you perk up. What do I care about? Incontinence. This really is so say the tumor is at 10 centimeters, but the patient has no continence. You really have a conversation about a permanent colostomy for them. So endorectal ultrasound, it's the two modalities for imaging for local, looking for nodal disease and local involvement is endorectal ultrasound and MRI. It's difficult to say superiority at one over the other. Some places don't have ultrasound. The MRI is not just a typical MRI of the pelvis. This is an MRI rectum where they put in contrast, and we don't have this fully available here to the degree. But this is what we trained with. It's just it's just really a surgeon preference, to be honest. And there's so much inter-user dependent variability. And obviously distant metastasis, CT, PET scans, and MRI are part of that. PET scans are not part of the initial workup for rectal cancer. What you need for your initial workup is a CT chest, abdomen, pelvis, and it's a CT chest, abdomen, pelvis, rigid proctoscopy, a CEA, and you need your either MRI or endorectal ultrasound. And the CEA, one thing I was taught here by a chief resident anecdotally, and it's always seemed a little odd, and it was wrong, was that a CEA, if it's normal at the time of diagnosis, you don't need to follow it the rest of their cancer. That's totally untrue. Because their reasoning was this cancer does not produce CEA. That's not true. CEA is a marker for metastasis. So somebody's a CEA their whole life, including through their whole therapy, and the year after for the rectal cancer might be normal, and then it starts to climb. That means it's metastasizing, and you need to go investigate. So you always follow a CEA on these patients. So DRE, rigid procto, in addition to full colonoscopy, because you determine so much more information from it, including height and relationship to the sphincter complex. CT chest, abdomen, pelvis with PO and IV contrast, MRI or endorectal ultrasound, and CEA. And it must be presented in a multidisciplinary tumor board in an actual rectal cancer center. That's something we don't have here. I've been working on it. But they've shown that first off, it improves patient outcomes, and second off, and including survival. And second off, it's been shown to change even what senior oncologists or senior surgeons were planning to do, even a very straight, and it's actually the straightforward patients that are a little bit, that change a bit. So, because you think, oh, who cares? It's a T2 and 1. Like, I know what I need to do for this patient. No. So, treatment algorithms. Current management of rectal cancer is not upfront radiation, chemo, then surgery, then chemotherapy afterwards in all patients. It's much more complicated. But involved in the therapy for rectal cancer, surgery, radiation, and chemotherapy in various orders and arrangements. The factors that are discussed in that tumor board to determine what is going to be our treatment algorithm is the anatomy. Do I think I can get a negative CRM? Even though I don't believe that lymph node is actually positive. The radiologist says, yeah, it's 8 millimeters. Cutoff's about 8 millimeters, maybe. And it looks suspicious, but when I look at it, I really don't think it's real. And this is the rectal cancer radiologist, and you say, well, I can get a good CRM. I mean, I have a 2 millimeters there between the surrounding structures and the edge of the tumor. So you'll operate up front. And also, in consideration, you're looking at the invasion of the sphincter complex, and then the depth of invasion, lymph node status, metastatic disease. So traditionally, so TME. This is what we talk about. It's the golden fleece or whatever of rectal cancer, is that perfect total mesorectal excision. And the mesorectum is, so when we talk about the mesocolon or the mesentery to the colon, it's just the mesentery to the rectum, and It's this envelope, this fatty envelope around the rectum that contains all the lymph nodes. And in the, it's difficult to get that out. First off, it's difficult to determine, is that perirectal, is that mesorectal fat, or is that fat outside of the mesorectum? But there is this beautiful plane there, and which can be difficult to determine when there's been radiation or tumor involvement, or there's been a biopsy or a prior local excision. But it's so important because this is the biggest determiner of whether or not they're going to survive. So as a surgeon, this is why rectal cancer surgeons are so tense when it comes to this part of the surgery. And it should be, there's grading there, and we don't do it here, but that's whenever you read colon and rectal literature, they grade the TME specimen. It's the Kresge grades, and I can't quite say it, but it's a pathologist. It's all named after him. And it should be, so a grade, so the highest grade is actually better. So so it should be shiny. There shouldn't be any rents in that mesorectal fat, and that fascia. It's really a fascia. And I mean, this is like the prettiest specimen ever. And at rectal cancer centers, they photograph their own specimen. The pathologists photograph it, and then there's a big argument in tumor board. By the way, you present the patients in tumor board multiple times. You present them at the time of diagnosis, and then after their neoadjuvant therapy, if that's what you did, and then you present them after surgery, and then I mean, just the whole way along. Anyways, so, and when you stay in that holy plane, the total mesorectal excision plane, you preserve those autonomic nerves because you're not creeping out in those lateral stalks, that fat laterally. And it's not quite the case when you're dividing the IMA and you're worried about the retrograde ejaculation. That's from ligation of your IMA. But it is when you're talking about ED and bladder retention. I don't really want to go too much into local excision, but really the advantage of local excision, if you can get away with it, you have saved that patient the morbidity of a life-changing rectal cancer surgery, either APR or an LAR. And they've done studies that show the more rectum by centimeter that you leave in vivo, the better their function. So by centimeter. So if you take out 1 more centimeter, they have less function. So if you're able to get by with local excision, that's ideal, but it's not proper for every patient. It should only really be done when you're going to be surveilling really aggressively. So small T1 and T2 lesions, and this doesn't mean that all you're doing is locally excising and you're done. Sometimes they still have adjuvant therapy. Currently, we really don't recommend it for T3 lesions. And obviously, if there's any nodal disease, you're not going to consider it. And these are some loose indications. I saw them in one test question. So less than 4 centimeters in diameter, that's only because you think you can get a good margin around it. You're supposed to have 1 centimeter margin when you excise it. Less than 40% of the bowel circumference, so you're not stricturing down the bowel. Within 10 centimeters of the dentate line. If you're up higher, just do an LAR. And you're going to be intraperitoneal, and this is a full thickness excision. And it needs to be freely mobile on DRE because, as we were talking about in the clinical staging, that means you're not involving other adjacent structures. And you need to obviously have had your pre-op imaging. And various ways to get at this for local excision. The ones we typically see are transanal. That's if it's really, really, really distal, and you can put in a Hill-Ferguson and mark out your 1 centimeter margins and then excise it. The other things that we see here are the transanal endoscope, so TEM, that's that resectoscope that goes in. And then there's TAMIS that I've been doing with it's an incision, single incision, the hand port for laparoscopic surgery. It's been adapted to this. But you can go through the coccyx for a Kresge. There's transsphincteric where you actually divide the the anal sphincter complex and open it up. And as you can, there we go. Let's see, the LAR techniques, this is just cool looking. But this is fun. This is when we do it from above and below. So we've done the TME from below, and then from above, they've been coming along too. And then we meet in the middle, and you just see this light, kind of like the Sistine Chapel. So APR, when the tumor invades the anal sphincters and they don't have continence, or you're concerned that you won't get a good distal margin, APR is your benefit. And this is a slide. I'll send out this information, but this shows your treatment options depending on this for stage 1. And as you can see, it's not all stage 1s are created equal. There's a lot that goes into it. That's why rectal cancer surgery is complicated. It should be presented at multidisciplinary tumor boards. And this is, I'll send these out. But for even if you've done initial resection, what do you do if it's a T1 and it's low risk features, meaning it's well or moderately differentiated and there's no lymphovascular invasion, you're done. But you're not totally done all the time. So, okay, we won't go over ERAS stuff. I'll just send out these slides. But ERAS is important to read about it, which is enhanced recovery after surgery. Okay. Ta-da! Rectal cancer.